Good afternoon and welcome to Patient Matching Best Practices for Collaboration and Data Exchange, a webinar tweet chat from Health Systems CIO sponsored by NextGate. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health Systems CIO, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today, so definitely send in your questions as they occur to you and leave the default set to all panelists. We'll take those later in the program. And you can download the deck by using the URL on your screen, and it has been sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to have our featured panel discussion with Kim Chaundy, Director of Operations with KeyHIE, which is part of the Geisinger Health System, Bill Pearch, Program Director with the Alaska eHealth Network, and Dan Cidon, CTO at NextGate. So we've got a lot of good stuff to discuss today, so we're going to jump right in. Kim, let me start with you. Can you give us an overview of your organization and your role there?
Sure. Thank you for having me. My name is Kim Chaundy. I am the Senior Director of the Health Information Exchange that we call KeyHIE. We have 188 unique healthcare organizations participating in our exchange, and we've been founded since about 14 years now. We have a robust service line, and I'm super excited to have an opportunity to be part of today's discussion.
Excellent. Thank you, Kim. Bill?
So I'm the Program Director for the Alaska eHealth Network. We are the statewide health information exchange for the state of Alaska. We're not a state entity, but they are one of our major clients. We cover all of the hospitals, provider practices, behavioral health, payers, and the state of Alaska as an entity for interconnecting and data exchange here in the state. We've been around for mumble 7 or 8 years actively doing health information exchange, and prior to that we were acting as the rec for the state of Alaska.
Very good. Dan?
Yeah, good afternoon, good morning, everyone. My name is Daniel Cidon. I'm the Chief Technology Officer of NextGate and I'm also one of the co-founders. I'm very proud to be leading the R&D team at NextGate, the family of folks that have been working on healthcare identity management for over 15 years. So looking forward to today's discussion and hopefully everyone will get a lot out of it.
Excellent. Very good. Kim, can you give us a little more information about KeyHIE and how it fits with the overall Geisinger organization?
Sure. So Geisinger is one of the organizations that is part of the Health Information Exchange. Just like Bill had mentioned from his perspective, we have hospitals, ambulatory settings, provider practice groups, long-term care facilities, home health agencies, payers, pharmacies, and EMS systems. So Geisinger is just one of the 188 that utilizes the Health Information Exchange, and most of the utilization is having us be able to move community data out to our partners.
All right, very good. And Bill, let's learn a little more about the mission and structure of Alaska eHealth. What kinds of organizations is it trying to facilitate patient data exchange among, and what kinds of data?
So we're what I would refer to as a fairly traditional health information exchange. We're trying to connect hospitals, private practices, whether they're primary care or specialty clinics. We're connecting behavioral health providers in, payers, and the state of Alaska for public health purposes and for registry purposes. So those are the kinds of things we're trying to connect with the goal ultimately of making, and I say this all the time so it sounds kind of cliche, but with the goal of making the information actionable. That's really what we're trying to make happen. We facilitate the data exchange of traditional HL7 type of messages, ADTs, ORUs, CCDs, but we're trying to make it more approachable from a provider perspective in that I'm not going to go and talk to a doctor about, hey, we got this ADT you should look at, or hey, here's a CCD that you can read. Instead, we're talking to them about, here's the information you need to do your job without having to guess. Unfortunately, in medical, oftentimes it seems that physicians are left to do a lot of intuiting and guessing because they don't have all of the information that they could have. And so getting that information to them is just vitally critical. As far as structure is concerned, we are a nonprofit. We were established by state statute, but we're a nonprofit organization, and we are essentially paid for by the state of Alaska, federal government through the IAPD process, our participants through subscription fees, including payers who are working with us to get information about their stakeholders in a timely manner so they can assist in getting the best possible care at the lowest possible price.
Excellent. Thank you, Bill. What are some of the challenges that each of your organizations face around patient matching? Kim, you want to start off? This is really, we get into the meat of it.
Sure. Thank you. So patient matching is something that is critical to be able to make sure and assure that we're able to move the clinical data throughout the community. It is a focus point when we onboard a new organization that we take a deep dive into their existing MPI and have them have an opportunity to, I'll say, clean it up a little bit prior to us going into our testing environment. Once we're in our testing environment and we're going through matching and making sure that everything is kosher and filing correctly, it's another opportunity for them to potentially clean up any mismatches or possible dupes. Throughout the kind of testing scenario, you'll find that it's a great opportunity to see where maybe your front-end staff is missing critical information that is weighed for matching the patient. So going back and re-educating your front-end staff how important it is to have the critical data elements, as well as the patient, engaging the patient and making sure that the patient understands that it's extremely important to always be given their birth name and not their nickname, and that they want to make sure that the information is always consistent so that we can assure that we are matching across communities.
So as you bring entities into the HIE, I'm sure you see all different levels of sophistication or data cleanliness or whatever you want, data hygiene. So I would imagine sometimes you bring someone on and they're run a pretty tight ship, and other times it's a mess. Is that true? Oh,
absolutely.
Yeah. So,
and yes, sometimes you have folks that think they run a tight ship, and when they really get into it, they don't.
Yeah, so it's almost becomes an opportunity for them, as you were saying, as they have to sort of clean up. It sounds like they have to clean up before they come in. Is it ideally that's how it works?
Yes.
Okay, and you, to what degree do you help them clean up or advise them? As you look at the data and say, here's what we've found, and here's what we think you need to do, and here's how much time we think it'll take you. Do they then have to wait until they're sort of brought on board until they remediate and take care of those things?
So we do have a minimal necessary requirement of certain data elements. So if they can't meet the minimal necessary, then they do have to go back and, update their system and allow that to happen. But from a cleanup perspective, we consider our members coming on as part of our team, and this is an ongoing process. So we communicate daily with them. Sometimes it could turn into weekly, but I think making sure their HIM staff, the front-end staff, and our staff collaboratively work together and understand that we need them to constantly be cleaning up or constantly being aware of how critical it is to get the entire data set needed to be able to score the patient appropriately.
Is there a correlation between size of organization and data hygiene, so meaning that the smaller practices are messier than the larger practices and so forth?
No, I would say no, there's not. Sometimes the smaller organizations are managed, not so many hands in the pot, so it is a little cleaner. And then on the flip side, I could say, yeah, maybe if you have more staff to pay attention to it, it could be a little more cleaner, but I can't say one or the other.
Yeah, you see all types. All right, Bill,
yes.
What are your thoughts around the question in general or anything we've touched on with Kim so far?
So I would say that our challenges are kind of the usual challenges as far as registration staff making human errors. The other challenge that we find ourselves having to deal with are different organizational processes, because I'm not dealing with a bunch of organizations that are in the same family. I'm dealing with Dr. Bob's office down the street, who has absolutely no business relationship with Dr. Sue's office on the other side of town, or the hospital in another city. So they don't necessarily want to adopt each other's standards or business processes. So dealing with those kind of different processes, different information gathering requirements that are specific to the business themselves is one of our challenges. The other challenge that we have are business processes that are just bad. And by bad, I mean broken as designed, where something has been implemented in a specific facility to meet their particular needs, that when they actually look at it, they say, yeah, I'm not sure how this is working, but we've been doing it for the last couple of years, so we've all kind of just adapted to it, such as naming of infants. Naming of infants is not only is it different, it seems, in every facility, but it can lead to a significant number of patient identification issues because of the way a particular facility happens to do their naming. We've had facilities that name infants the same name as the mother. We have facilities that do baby, comma, last name as the naming convention. So those processes that a business has put into place in order to meet an immediate pain point that weren't necessarily well thought through wind up coming back to bite them and to bite us in the master patient index process. And what we've seen is that oftentimes it's those mid-range organizations that have the biggest problems in the consistency of their data and in their cleanliness of their patient index. And it really has to do, I think, with economy of scale. When you're a very small organization, you don't have the volume to really drive the quantity of issues, and so a lot of times they're able to keep up on things and keep it clean. You've got one person or two people who are very well trained running the front desk that actually do it consistently day to day, year to year, whereas you get into a mid-sized organization and you have enough turnover that the registration staff don't necessarily have the practice that a smaller organization might have, and you certainly don't have the back-end support and the tools necessary to keep things clean on the other side. So I find the mid-range organizations are the ones that have the biggest problem with keeping their patient index clean.
Yeah, that does make sense when you think about it, so not surprising. Dan, let's bring you in here. Are there common band-aids that organizations try to employ around patient matching that wind up falling short of the solutions that sort of Kim and Bill have chosen?
Yeah.
So when organizations bring you in, what are you hearing or what are you seeing in terms of this is we did the best we could. We're trying to deal with patient matching without a solution like yours, or before we've had to seek it, but we've fallen short. So what are people out there doing, and why is it falling short of sort of a full-on NextGate type solution?
Yeah, I mean, I think what we see are kind of two variants of that. For some organizations, they try to kind of develop homegrown solutions or homegrown processes that glue together various systems together, and just kind of using very simple algorithms, around maybe some phonetic name matching or deterministic logic. They're able to, to get into the mid 80s, maybe even 90% of the matching. It's just that last 10%. Is where they really start to feel, the pain. how complex matching can be. And 10% of the records is a very significant patient population. The other kind of spectrum that other end of the spectrum that we see is that some of the EMR systems have some built-in capabilities around, at least to some extent, mastering some of the identity within their own systems, within their own silos, and some of them have some capabilities around storing identifiers that are external to them. But the problem that we see there is that as the ecosystem develops and more systems are plugged in, it's very hard for any one system to kind of to dictate what the patient identity is. And really where the EMPI has its most value is not just in establishing the matching and some sort of an enterprise ID, which is certainly valuable in and of itself, but actually having a full visibility on all the different streams of demographic data that's coming from all the contributors and being able to treat each and every one of them as kind of first-class citizens, as opposed to, hey, you need to get the identity that, I won't name a particular EMR, but EMR X, says is the identity. And I think that makes for a much more flexible, future-proof solution than relying on any one, particular EMR.
Interesting. So just to reiterate, you're saying that people out there doing their own thing might be able to get to 80 or even 90, but it's the last 10% that they're going to have trouble with. Is that correct?
Yeah, I mean, it's a bit of a hockey stick. If you look at the graph about the amount of effort and sophistication that's required, because then you start to get into issues around tracking and managing prior history, multiple addresses, multiple names as names change, and lots of other kind of very common data anomalies that we see. And I'd also say, for the other end of it, with with EHRs, it's a known fact and statistic out there that most of those systems have 15 to 20% duplication rates, even within their own repository. So they're not even able to kind of manage all this complexity.
Very good. Bill, do you want to talk a little bit about that? I mean, you're working with NextGate, but before you were, what were some of the challenges? So, why did you feel like you needed to sort of kick it up a notch?
So the HIE business, when you get right down to it, our business is in identity management. We have to identify the patient. So we've actually been working with NextGate in one form or another since we started the HIE part of the organization. They've been our partners through thick and thin. And so, to be perfectly honest with you, I can't tell you what the challenges were before we went to an MPI, because we started with an eMPI. I can tell you what I see in facilities that we're connecting who are having registration issues and having issues with patient identification, that in general the Band-Aid seems to be depending upon after the fact back office remediation, up to and including using billing as a mechanism for identifying registration errors, which is a horrible way of going through life. And the other thing that we see is that people simply do without the information. They just accept that they don't have the information about a patient when they look up a patient in the EHR, and they continue to just put the information into what I would refer to as the wrong record, and you wind up in a situation where you could potentially have a patient safety issue or an efficacy of care issue, and people just suffer through rather than taking appropriate steps to really take care of the issue.
Kim, similar situation to Bill, or any other thoughts on, were you dealing with things without a full-on solution for a while and trying to make it work?
No. Yeah, so unfortunately, no. My experience has always been with NextGate or another solution, but I do have to, agree that some of the existing workflows of correcting it at the back end is something that we try to discourage, trying to make sure that they understand this with the health information exchange. Absolutely, we got to match the patient because this is real-time delivery of clinical results. So we want to make sure that we're getting as much information up front as possible. We went as far as suggesting that you challenge your front-end staff to perform at a certain level and either incentivize them or kind of gear this towards their evaluation so that they have some skin in the game and they understand how important it is.
Right, right. Do you see a difference, Kim, in HIEs? It sounds like HIEs absolutely need the MPI. Like you can't even exist without it, versus a healthcare provider that either has grown or is growing and may go from a situation of being able to live without one to not being able to live without one. Is there a difference there between sort of an HIE and a health system?
So really, I would envision a health system almost being like an HIE, trying to make sure they're managing all of their systems with a unique identifier. I would see it or envision, someone who was on paper and now just transitioning over to an electronic system and maybe, in that category, not understanding the value of having, an eMPI.
And Bill, your thoughts on the need from, let's look about it on the provider side. Is there a size at which you grow to a certain size that you need a solution like this, or as you expand or as you've acquired and you've grown, when does the need kick in?
I think the need kicks in even in a single provider doctor's office. I think, though, that the availability of the information and the cost that can be involved is huge. But if you could take your single provider doctor's office and do patient matching against some sort of regional, statewide, or geographically based MPI, it would save those providers so much work. Where they're having to correct demographics to get the billing right, even just getting the information from another facility. So even if you don't use the HIE to get information back and forth because you're a doc in a box and you've got to log into the hospital EHR, actually having the appropriate information, kind of a records locator service, to be able to correctly identify that patient in that foreign system that you can log in and get to has huge value.
Dan, we got a question in from the audience wondering what you would consider to be the minimal necessary requirements for patient matching. And I'm not sure if that means to have a patient matching solution or to do patient matching. But take it both ways.
Okay. Usually when I hear that question, it's usually around how much data is required to have a reasonable match rate. And what we say to folks is that we need more than just a name and a date of birth. Because you take any one name and look at how many people were born on that particular day, and that year, it's actually a large number, right? So what we need beyond that is something that can help pinpoint either things based on like their location or communication information such as phone number or email address, especially mobile phone numbers. People tend to hold on to that for quite a long time. We've had far less reliance on things like social security numbers, but even the last 4 digits, things like a driver's license. There's all sorts of different things, but the bottom line is that you need more than just a name and a date of birth. But for most organizations that we work with, they routinely collect more than that. I think it's as Kim was saying, it's just important to have a consistency with the front end staff. That's the first point at which a patient has their experience with the organization. That's the point where you really need to try to capture things consistently. And then the whole patient experience ends up being better from that point onward.
Very good. All right. Kim, let's start with you on this. What should a sophisticated patient matching solution allow you to accomplish? So how does life function when you have one? How are things easier?
Well, they're easier because there's not as much, I'll say, investigation work from your team's perspective. If the system can do the matching with the data that is presented, then it allows the entire workflow to just kind of happen. If we're not able to match with the appropriate data that was entered, then it typically goes to a report or to a queue for someone to manually look at it and use other type of resources to try to match it up. So it can delay delivery of results to a provider, or it can delay, other items that, we want the best experience for the patient. So I think it's very important getting it up front.
Very good. Bill, thoughts?
I would like a sophisticated patient matching solution to allow us to match patients up to, and in some cases including blatant gross registration errors, and to be able to identify those edge cases, such as twins, as an example, where the data on the twins is so close. Social security numbers can be a digit off. Date of birth is the same. Last name is the same. First names could be very similar. Those kind of situations are really hard sometimes for an automated system to capture. So at least being able to flag those, to identify them so that we can actually do that investigation successfully is critically important.
Dan?
Yeah, I think that I would echo the comments of Kim and Bill. It's the edge cases that tend to be the most problematic. And, within our arena of healthcare, it is absolutely pivotal that we not make any mistakes. If people would rather see two records, a record show up twice, in a search list, than for the wrong information to be overlaid, on top of a single record. So a lot of our work goes on preventing records within the same household or other kind of edge cases around emergency departments and newborns and all that from causing problems. I'd say also that a good matching solution needs to take into account that the data is volatile. So even if the data is entered in absolutely correctly, and it almost never is, then things change, right? Your last name changes, your address changes, your phone number changes, attributes change, and depending on how many systems you have connected, not all of those systems are aware of that change. So it's important that the central registry, that the MPI, maintain that history and use that history as part of the matching process to ensure the most likelihood that the records will be appropriately linked together.
All right, very good. We got another audience question in. An overlay occurs when one patient's record is overwritten with data from another patient's record, creating a combined inaccurate record. Is this something that Kim and Bill's team deal with? And if so, what is their approach to dealing with this issue? Kim?
Can you repeat that again? I'm sorry.
Sure. An overlay occurs when one patient's record is overwritten with data from another patient's record, creating a combined inaccurate record. Is this something that Kim and Bill's team deal with? And if so, what is their approach in dealing with this issue?
Yes. So unfortunately, there's always going to be human error, and yes, it does happen. When this does happen and it does occur, we inactivate the accounts immediately so that nothing can go out or nothing can come in. And then we go back and do an audit or a check, a manual audit or a check, and move the data to the appropriate medical record number and assure that everything on the medical record is indeed for that person, and then we reactivate the MRN number.
Bill?
So we're not the record keeper. So when we have an overlay situation occur, the first thing we have to do is determine if it's an appropriate overlay or an inappropriate overlay, because there are a number of situations where an overlay is entirely appropriate. Name changes, address changes, and name changes happen. People get married, they change their name, they move, and so those are situations that could cause an overlay to occur that are entirely appropriate. So doing some checking on, is this an appropriate overlay or not, is kind of the the first step. And then, since we are not the keeper of said information, we can, if it's inappropriate overlay, we can disable the overlay that is inappropriate, and we contact the source system to let them know of what in most cases is some kind of gross registration error, so that they can correct their records and send us the updated information.
Dan, any comments you want to make on that issue?
Well, it's actually a huge issue. I know that we've had a number of discussions with customers on this, and our approach to it has evolved over time. The initial approaches that we had in managing this was essentially to report out to the administrators of the MPI when we think an overlay has occurred. And as Bill said, it's not always easy, right? Because sometimes there are certain use cases like adoptions or other kind of common scenarios where, yeah, the identity changes. It's hard for us to determine whether the identity had changed in an appropriate way or not. In more recent years, we've been seeing that people want us to actually handle this even more aggressively, and especially with HIEs, because what they often do is transmit information from organization X to organization Y. And if that is done inappropriately because the data has been overlaid, then they get into some regulatory issues around that. So part of what we've introduced into the MPI is also the ability to essentially shut down that record or flag it from the perspective of the participating organizations to say, hey, if you're going to be transmitting information about this patient, hold on, don't send it right now because we're kind of in the middle of determining whether or not this is truly an overlay. So yeah, absolutely, it's a good question, and it's something that's as important as matching itself is kind of almost the reverse, of making sure that records are not getting overlaid.
Very good. Next question. And let's start with Kim on this. Do you have an estimated number of overlays that occur each month? The word used is overlaps occur in a month. Do you have an estimated number of overlaps that occur in a month? Kim?
So that's a good question. And I would have to say, now, I think Bill had mentioned we always want to go back to the primary source to correct the actual overlay. So I'm going to report probably to the ones that escalate all the way to the HIE. And in any given month, it could be 1 or 2, but there are times when it can exceed up to 10 or 12, but that's not common.
Bill?
It's less than 1%. It's way less than 1%. And giving you an actual number is kind of not terribly useful unless you have the additional statistics about our volume. Something to keep in mind is the entire state of Alaska's population is 740,000 people. Kim probably has that population reporting into one facility. So it gets a little bit weird when you start trying to compare numbers.
Okay. Very good. Kim, there's another audience question touches on a little bit of what we discussed before. Do either of the HIEs, meaning yours or Bill's, require a duplicate rate to be X or less prior to onboarding new participants?
So we don't require a actual percentage, but it is something that we strive to work through with them to decrease their possible dupes. I would love to enforce that, but I would say that probably would not allow us to move as quickly as we have in the past. So we kind of sometimes shoot our foot ourselves and then have to clean up later. Because a lot of our onboarding does tie back to grants, so it's grant related and has to be done in a particular time frame. But like I said, that's why our initiative is that we never stop trying to clean up the MPI. It's always on our minds every single day.
Very good. All right, next question. What are your thoughts on the need or possibility of a national patient identifier? Dan, let's start with you on this.
Yeah, we actually spoke on this topic at a recent conference in Boston. So absolutely, we support any endeavor by the government to try to create a patient identification strategy in the United States. I mean, forget about what the implementation may be. whether it ends up just being a single identifier, the way England decided to do it with the NHS number, or something more sophisticated than that. Anything that starts the dialogue again of how do we do this better is absolutely something that we support, because the way that we are doing things today, by essentially using demographics as your identifier, really anybody looking at this thing logically would say that that's a poor way of doing identification, right? Because you're relying on things that are not easy to convey accurately across systems or between people. And it's something that's volatile and changes. And it's also something from a privacy perspective, if somebody uses your demographic identity or compromises that and now uses that to open up a bank account or other kind of pieces of other kind of services, how do you claw back your demographics? You can't change your name, you can't change your date of birth, whereas an identifier, a properly constructed and well-conceived identifier, could certainly be one where you can revoke the identifier and issue a new one if somehow it's been compromised. So absolutely, we're supporters of it. We do feel that looking at other countries that have gone down this path, 20 plus years ago, such as in England and in Scotland, that it's something that's going to take a long time to see the adoption. It's still something where the MPI has a lot of relevance in using that identifier as part of an overall matching strategy and as a data governance platform. But as I say, we're absolute supporters of it.
Very good. Kim, any thoughts around a national patient identifier?
Dan said it very well. I do support it. I think it is a great idea. I do also believe that there are going to be possible duplications there as well. I look forward to the opportunity of seeing how they'll, develop and incorporate it into not only just HIEs, but, EMR practices. So I look forward to the opportunity.
Okay, Bill?
I think that we're not going to see a national patient identifier for a long, long time. And I attribute this to something I call the privacy paradox, where the more an individual would benefit from being identified correctly, the less they seem to want to be identified correctly. I think that, it's crazy, but it's true. I think that the next step will be something a little bit more regional, more along the lines of a KeyHIE model or geographical, where we'll start to be able to leverage things in multi-state regions, and ultimately over time that could potentially grow into kind of a backdoor national identifier of some sorts. But I think that based on the current regulatory environment, we're just not going to see a national identifier for quite some time.
All right, we have some more audience questions. For the HIE representatives, if a participant organization has a well-established and clean EMPI system linking their own systems, do you deterministically respect those links or still apply your own algorithms, or is there some combination you do? Bill?
We're going to treat every record that comes in as a potential record to be matched. So just because someone says this is patient Bob, we're going to have to match up patient Bob with our patient Bob. So it's not that I'm going to say that your patient Bob isn't patient Bob. It's just that I need to do the matching on my side because I'm doing the longitudinal record across organizations rather than just connecting to an organization.
Kim?
Yeah, so we'll constantly or continue to respect what they send us, but we'll have to do our matching. And if there is a discrepancy, we are going to always resort back to the primary source of where the data came from. How they choose to match theirs, that's how they want to keep their MPI, but we will continue to match based on our algorithm as well.
Very good. All right, Kim, let's stick with you. Another audience question. It's a very inquisitive audience today, which we like. Do you use some sort of onboarding process to help establish active care relationship when you partner with a new practice or provider? Do you feel this helps reduce patient matching challenges?
are they referring to, do we receive a load of their patient population from like a practice so that we can match their patients to the providers? Can we ask for more clarification there?
Well, let's assume that it's what you think it is and answer it that way if you would.
Okay, so from a matching perspective, when we're matching up our patients, we do read into the HL7 message not just their demographics, but their physician relationships that they have, so that we can tie a relationship to a physician to a patient, because that also does sometimes help with your matching algorithm when it comes in from other organizations that you can say, you know, Jane Smith's PCP is Dr. Smith. So we do match up not just the patient to the demographic information, but we do auto-match relationship, which we call to the providers.
Bill, any thoughts on that question?
We don't do patient attribution in that regard for information flow. So we do make use of the information to create a record locator service, but we're not using it for that patient attribution to a provider. We handle that through a separate process.
All right, very good. Next question. Where do you think the future of patient matching lies? In biometrics, blockchain, machine learning? Kim?
So I think blockchain is a little far out. I think the opportunity from a fingerprint or from an eye scan is, I think, a little closer than, you know, the blockchain. And we're starting to see it just out in the industry with patient or proper identification in an airport. So I would see that coming sooner than the blockchain, in my opinion.
Dan?
Yeah, that's a really interesting one, Anthony. So, you know, I would say that biometrics has some challenges, especially within healthcare. So yeah, we do see it in kind of security applications, border control, and things like that. But those tend to be far more controlled environments. People are showing up with biometric passports and other things like that. So I think that's been kind of the problem with introducing biometrics, you know, into healthcare. And it's also been an issue for minors and those that, you know, really can't use that kind of equipment. It's not physically possible even in some cases. I do think that the future really lies heavily in the area of mobile applications and wearables. I think that, you know, today practically everybody, you know, has a device like that or can be the guardian of somebody that has a device like that. And with all the technologies that are available, you know, as far as determining your location and placing identity information into your phone, I think that could certainly streamline the registration process and you know, really at some point get us to that 100% mark of matching, because your identity is essentially stored on your phone and you're transmitting that. Of course, the rest of the industry, you know, and all of the myriad systems that are out there today that are points of registration would have to catch up with something like that. But I do feel that in the long term, it's really these mobile applications and wearables that's going to help identify us in a secure way and in a way that we can choose how much of our identity is, you know, is released and disclosed.
Bill?
I think as we look in the next 5 years, we're talking about refinement of what we currently have and the enhancement of using different data sources to make it a more data-rich matching process. I think as we look out to about 10 years, then we're starting to get into perhaps some biometrics, and probably 15 to 20 years away from really being able to use blockchain-style matching. They're going to be early adopters, of course, but you know, people are weird, and there's going to be a lot of concerns about privacy and Big Brother looking in and things like that.
Very good. All right, let's go to my favorite feature, which is Ask a Co-Panelist. So this is the opportunity for our panelists to ask each other questions. So Dan, why don't you start off? Ask one or both of your co-panelists a question.
Sure, I'll ask it to both. It'll be a quick question. I've always been curious about this. Do you feel that awareness of the problem of patient identity has changed over the last several years?
Bill, you want to start?
I think that awareness has changed at the hospital level and certainly at the payer level. But I think that from an individual standpoint, it really hasn't changed that much. I think that people are becoming more aware of the impact of medication errors, procedural errors, wrong site surgeries, things like that, driven by these identification issues, but they haven't really come full circle into understanding the root cause. And so it to understand the importance of patient identification being effective and how that can impact them personally and directly.
Kim?
Okay. I do agree. I think from a healthcare perspective, it has come up to bubble up to be more of importance and better awareness. From a patient's perspective, I think if you have a sensitive patient, one of those inquisitives, don't want their data out anywhere, I think they're kind of more in tune to it. But from an everyday lay patient just coming to get their, blood work drawn, I don't think there's a true awareness of how important it is.
Interesting.
Very good. All right, Bill, do you have a question for your co-panelists?
How do you see the possibility of leveraging master patient index services as a service to organizations rather than just a function that you use to make your organization run more smoothly?
Dan, you want to take a whack at that one?
Well, I mean, definitely, the notion of an MPI or patient identification as a service has been one of the drivers that has pushed us towards deploying our application stack in the cloud. Because if you think about it, it really should be almost like a utility that you can plug in various streams of data, and out of that stream, do the best that you can in terms of determining the patient identity, and then offer services like an enterprise level search, or services that help participating organizations pull down lists of problem spots, whether it's overlays or duplicates or whatever. So I do think that there is an opportunity, likewise then, for HIEs to look at it that way. It's like, here's a utility, we're hosting it for you, we're paying for it, and this is what you can do.
Kim?
So it's actually a very good question. It was going to be kind of part of the question that I was going to ask. To offer a service like that, is there an opportunity for us to add an additional service line on top of our MPI to assure that there are abilities to question or properly match a patient in the industry, like you do so sometimes when you're asked where did you live 10 years ago? So very good question. It's something that we've been toying with, trying to figure out, but I don't think I would venture down that road yet until I was 100% sure that we had, a clean, very, very, very clean MPI to offer that service.
Very good. Kim, did you want to ask another question to your co-panelists?
So my curiosity is are they considering trying to add a service on top of the MPI to assist or aid in additional matching criteria?
Is that for Dan? Just for Dan?
Sure. No, we'll start with Dan.
Both? Okay.
Can you guys hear me now?
Yeah.
I'm so sorry. I don't know why I cut out there. Yeah, absolutely. So, part of what we introduced earlier this year was a platform called Augment. And with the recognition that the streams of data that we consume today that help identify the patient are not always accurate enough or complete enough in order to determine who the patient is. So with Augment, we have the ability to reach out to third-party reference data providers that can fill in some of those gaps. And gaps looking at the history, the address history, or contact history of the patient. And sometimes that's the critical little link or piece of information that's required in order to do a match that the data that was coming from the participants was unable to do. So, yeah, absolutely, we do recognize the need for that.
Bill?
For us, it's simply a math question. What is the cost for dealing with all of the potential matches that need to be adjudicated versus what is it going to cost to bring on an additional tool? And so as long as our volume and our potential match, potential duplicate rate remains low, and it's cheaper to have an individual do that, then that's what we're going to do. When the cost of dealing with that MPI cleanup gets high enough that it becomes a pain point and we need to move to a tool to save money, then we're going to do that. So it's just a math question. But yes, we're continuing to look at that, and as demand drives it, we will move that direction.
All right, very good. Dan, I just want to give you an opportunity for some final thoughts here before we let everyone go. Your advice for CIOs, others on the line who are working at health systems who are grappling with this challenge?
Well, I mean, I think the challenge that we'd put out there is if you aren't taking patient identification seriously and you don't have some sort of a continuous strategy to improve upon it as the technology and processes change, then really it's putting the patients, and the reputation of an organization at risk. So I think that, while there's a lot of new things in the industry, a lot of shiny, new technologies that come out there, I think just focusing on the basics of patient identity always has to be front and center.
Okay, very good. Got to make sure you're getting that done right up there with security, right? All right. Well, that was about all we had time for today. What a great conversation and a great panel. Regarding continuing education, those of you who hold the CHIME CHCIO certification get 1 CEU for attending our events. So let CHIME know you were here, and if you've asked us to do so, we certainly will. You'll receive an email when the on-demand recording of this event is ready for viewing. To sponsor one of our upcoming events or book a custom event, you could reach out to Nancy Wilcox from our team. Then you can go to our website to register for upcoming webinars that we have scheduled. So with that, I want to thank our featured speakers, Kim Chaundy, Bill Pearch, and Dan Cidon. And I want to thank our sponsor, NextGate, for making this possible. And I want to thank you, our attendees, for coming to our events. And with that, everybody have a wonderful day. Thank you.
Thank you.
Anthony.